switch it.
Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and I'm joined today by Dr. Mary Carter Denny, vascular neurologist at MedStar Georgetown University Hospital, and Dr. Anna Aguirre, MedStar Health physical medicine and research physician and research fellow at MedStar National Rehabilitation Hospital, who is bilingual and will be interpreting parts of the program for our Spanish-speaking audience. May is Stroke Awareness Month, so now's the time to educate yourself on the different types of stroke, how they are managed and treated, and to learn how to reduce your risk. We're going to talk today about the new RAPIDO acronym that helps Spanish-speaking people recognize the signs and symptoms of stroke. RAPIDO is the Spanish language version of Be Fast, if you've heard of that, where T is for time to call 911 to get medical care immediately. So thank you for joining us today. Give us a like, let us know you're watching. And if you have questions for Dr. Denny or Dr. Aguirre, please ask them in the comments. Before we get started with our questions, let's get to know our experts. First of all, welcome. Thank you for joining us.
Thank you so much for having us. I'm Dr. Denny. I'm a neurologist with MedStar Health, and my clinical practice is at MedStar Georgetown University Hospital. And my research practice is here at MedStar National Rehabilitation Hospital. And I'm excited to be here with you all today, as May is Stroke Awareness Month, talking about both Be Fast, which is the acronym that helps us remember the important stroke signs and symptoms in English, and also to launch the newer RAPIDO Spanish language acronym with the help of my colleague Anna, because we recognize the importance of recognizing stroke symptoms among Spanish speakers, and also emphasizing the importance of getting medical care quickly if you or a loved one were to recognize the signs and symptoms of stroke. Without further ado, I'll let Anna introduce herself, and then we'll get going with our RAPIDO presentation.
Hello, everyone. My name is Dr. Anna Aguirre. It's a pleasure to be here with you, and I will be helping in part of the RAPIDO acronym, or el acrónimo de RAPIDO, and to give some insights on the Spanish part of it. Thank you very much.
All right. Well, thank you so much. Really appreciate you both for being here. So let's talk about RAPIDO acronym that helps our Spanish-speaking people recognize the signs and symptoms of stroke. Dr. Denny, do you want to go ahead and share that with us? And I will go ahead and share a slide that has a view of what RAPIDO is. So do you want to share with us?
Sure. Yeah, I'd love to tell you about the I'd love to tell you about the background of RAPIDO. So I did my fellowship training in Houston, Texas, and with a group of colleagues there, we realized that the English language acronym for stroke signs and symptoms, Be Fast, doesn't translate well into Spanish. And Spanish is the second most common language spoken all over the United States, especially in Texas and also other major cities. So I worked together to develop a Spanish language acronym that could also, help people who are Spanish language speakers to recognize the signs and symptoms of stroke. And it was actually adopted recently within the last year by the American Heart and American Stroke Association. So now there's a national campaign to promote RAPIDO, and we're really excited about that. And so I'll just go through very quickly, just to let the English-speaking audience know that RAPIDO means fast. Then I'll ask Anna to kind of go through what each of the different letters means. Really excited that this has been launched so that we can provide care and more patient education throughout our communities for Spanish-speaking individuals. So I'll let you take it away, Anna, in explaining what each of the words, what each of the letters means in our RAPIDO acronym.
Muchas gracias, Carter. Y bueno, la doctora Denny se dio cuenta de la necesidad, cuando estuvo en Texas estudiando y trabajando, la necesidad de tener algo que fuera la traducción de Be Fast en español. Y Fast es rápido en español, y entonces surgió este acrónimo. Y el acrónimo va por todas las letras de rápido, empezando por R, que es rostro caído, que es una de las signos iniciales cuando uno tiene un infarto cerebral. La A por alteraciones del equilibrio, que podrían tener alguna alteración en cuanto a la fuerza y llegarse a caer, o alteraciones del equilibrio. Pérdida de fuerza en el brazo o la pierna, ya sea del lado derecho o del lado izquierdo. Impedimento visual repentino, que de pronto alguno de los campos visuales bilateralmente de los dos lados o solo de algún lado tenga alteraciones en la visión. Dificultad para hablar, que empiecen a cambiar las palabras o que empiecen a hablar de forma que no se le entiende. Y la última y muy importante, la O por obtén ayuda, llamando al 901 o 911. En cuanto estos signos se vean, ya sea solamente 2, 1, se debe de llamar al 911.
Thank you so much, Ana, for going through that for all of our Spanish-speaking patients. And I'll just summarize what you said, which is that, each of the letters represents a stroke symptom. So, rostro caído stands for facial droop. Alteración del equilibrio means dizziness or feeling off balance. Pérdida de fuerza en un brazo o una pierna, that means loss of strength in an arm or a leg. Impedimento visual repentino means loss of vision, which is also a potential stroke symptom. And then the last one, D, is for dificultad para hablar, which means difficulty speaking or problems with speech. And the O stands for obtén ayuda, llama al 911, which means to get help and call 911. So that's the translation from Spanish back into English of what rapido means. And really the important thing here is to recognize signs and symptoms of stroke and to call 911 to get help fast or rapido, so that we have the best chance of helping you recover from your stroke and the best chance of being able to be a candidate for time-sensitive treatments for stroke, because some of our treatments work the best the sooner that you get them. So that's kind of our overview of rapido, and we'd be happy to take any questions regarding rapido at the end of our presentation. But we're really excited about this new tool to just ensure that all of our Spanish-speaking individuals and families, from grandparents to children to adults, are able to hopefully more easily recognize the signs and symptoms of stroke and know that how important it is to call 911.
Sí, entonces la doctora Denny hace un gran énfasis de la importancia en la O de rápido, llamar rápidamente en cuanto cualquiera de estos signos se identifiquen para un rápido tratamiento, pronto tratamiento, y obviamente las posibilidades de recuperación son mejores entre más rápido se trate. Entonces, la traducción de Be Fast y rápido es una traducción que queda muy bien para lo que se necesita en cuanto se identifiquen los signos y síntomas de un evento vascular cerebral o un accidente vascular cerebral.
Thank you so much, Ana. That's great. We appreciate you joining us for this first portion of the program. We're talking about rapido, and we appreciate having a native Spanish speaker here to go through that with us. So Karen, I think we can move on to the next section, and Ana will stay with us as long as she's able until she has to see her next patient.
Okay, great. Yes, thank you so much. Really appreciated that overview, and especially appreciated being able to have that translated into Spanish for our Spanish-speaking viewers. So thank you so much. Want to talk more about signs and symptoms of stroke and really more about how we treat our patients who are experiencing a stroke, or what family members should be doing if they believe someone is experiencing a stroke. So let's start just by talking about what happens during a stroke. What makes them so scary? When you hear stroke, you think, oh my gosh, that's a really scary. And we know rapido there is quickness to treating a stroke. So that can add to the scariness of it. So what makes it so scary and what happens during a stroke, Dr. Denny?
Yeah, I think those are really important questions. So sort of a two-part question here. So what's really scary about a stroke is that somebody can be going along and, at work or at school or just going along with their day, and all of a sudden are suddenly unable to do something that they could do before. And that's the scary part because it's very sudden in onset. And I think that's the piece that's the most scary. So somebody who's able to talk and then all of a sudden isn't able to speak, or somebody who's able to, type on the computer and then all of a sudden can't control their arm or their hand. I think that suddenness is what's really scary. And the reason that the onset is sudden is that in a stroke, the blood flow to part of the brain is blocked off by a clot or a plaque. So the part of the brain, for instance, that controls our language and our ability to speak is usually in this left front part of the brain. And so if the blood flow to the left front part of the brain is blocked off, then that part of the brain isn't getting enough oxygen, isn't getting enough blood sugar, and it stops working. And therefore that function of the brain, which is to speak, doesn't work for that period of time. So I think that's exactly what a stroke is. It's lack of blood flow, lack of energy to any part of the brain. Most strokes are the blood clot type, where it's blood flow is blocked off by a blood clot or a plaque. There are a smaller number of strokes where the blood vessel actually bursts open, but that also doesn't allow the right adequate blood flow to the brain tissue that needs it in order for us to do all the things we do every day, like speak and move and feel and balance and see.
All right. Thank you so much. We're already getting questions from our audience. Dr. Denny, I'm going to ask you a question from William. He's asking, and this is a question that I had too, talking about the different types of strokes. William asks, what is the difference between an epileptic seizure and a stroke?
Yeah, so that's a great question. So both seizures and stroke affect the brain. In a stroke, you don't get enough blood flow to part of the brain, so that part of the brain stops working. In a seizure, part of the brain has kind of like an electrical storm, and all of the nerve cells, all of the neurons are sort of firing at the same time. And that causes the symptoms of a seizure. So for instance, we think of stroke as the loss of function, and a seizure is sometimes thought of to be as like the overactivation of function. So for instance, in a stroke that involves your, let's say your left arm, that would be controlled by the motor, the strength area of the opposite side of the brain, so the right side of the brain, and you wouldn't be able to move your arm. You would lose control and have no ability to move that arm. In a seizure, that arm might shake or jerk uncontrollably. So you don't have control over it because there's sort of an electrical storm of that part of the brain, and it's kind of working on its own without your ability to control it. And so I would say that that's kind of the difference between an epileptic seizure and a stroke, is that thankfully, typically epileptic seizures don't cause permanent damage, but unfortunately strokes can cause permanent damage. And usually strokes are loss of function, where a limb will stop working, for instance. And in seizures, the limb might, like your arm or your leg, might move uncontrollably. I hope that makes sense.
Okay. Yeah. Thank you so much. So that helps explain the difference between a seizure and a stroke. Can you talk about the different types of stroke? What is
Ischemic?
Ischemic,
Yeah.
thank you. Ischemic stroke and a hemorrhage stroke. Can you talk through each of those?
Yeah, absolutely. So there are two different main types of stroke. One is called ischemic and one is called hemorrhagic. About 85% of strokes are ischemic, and that is when, as I was sort of speaking about before, that you have a blood clot or a plaque, which is usually like a piece of cholesterol that blocks off blood flow to a blood vessel in the brain. And so most strokes are ischemic strokes. In a hemorrhagic stroke, that blood vessel actually breaks open and you have bleeding in the brain. And that's more typically from specifically from very high blood pressure or a few other conditions. But those are the two different, sort of mechanisms. One is ischemic is 85% of strokes, and that's a blood clot that blocks off the blood flow. About 15% is hemorrhagic strokes, where a blood vessel actually breaks open.
All right, thank you so much. What are the symptoms of those types of stroke? Are they the same as?
Yeah, actually, that's really important to know. So the symptoms are the same. So the symptoms of an ischemic stroke or a hemorrhagic stroke are often exactly the same. And that's really why it's particularly important to come to the hospital immediately so that we can get a scan of your brain, often a CT scan of the brain, to see if it's the bleeding type of stroke, a hemorrhagic stroke, or the clotting type of stroke, which is called an ischemic stroke, because the treatments are different. And you could have exactly the same symptoms, all of a sudden unable to move one side of your body, unable to speak. And it could be either from a blood clot blocking off blood flow, causing an ischemic stroke, or a blood vessel that's broken open, causing a hemorrhagic stroke. And the treatments are basically opposite. So that's why it's so important to come to the hospital right away and be treated. And often that involves imaging, particularly a CT scan of the brain, which can be done very quickly and done right away when somebody arrives to the emergency department.
Okay, great. Thank you. So yeah, we talked about Rapido at the beginning of this broadcast. The English version of that is Be Fast, but they both have fast in them. As you mentioned, it's important to get to the hospital early. Can you share the Be Fast version, which includes the symptoms of stroke in English?
Yes, absolutely. So Be Fast is the acronym that we use to identify stroke symptoms to help people remember what they are and also emphasize the importance of getting to the hospital quickly. So in Be Fast, the B stands for balance, so sudden loss of balance. E stands for eyes, so sudden loss of vision in one or both eyes, or double vision. F stands for face, so if there's a facial droop. A stands for arms, so is the arm suddenly weak or drifting down when you try to lift it up? Speech is, does somebody's speech sound slurred or they're having difficulty speaking? And T is for time. So if any of those things happen, then it's time to call 911 immediately to get help so that we can figure out what type of stroke it is, if it's a stroke, and if it's not a stroke, what else it could be, so that we can get you feeling better.
Great. Thank you so much. Appreciate going through that. Can you talk about treatment? So once if you are dealing with a stroke, whether it be the ischemic or hemorrhagic.
Ischemic or hemorrhagic. Yep, I got you.
Thank you. How are they managed and treated? Are there differences in how they are treated, or are they treated the same?
Yeah, that's a great question. The treatments are very different. So for an ischemic stroke, which is the type of stroke where a blood clot blocks off blood flow to part of the brain, that's the majority of stroke. That's about 85% of strokes. There are two main treatments. The first treatment is a clot busting medication that you could be given in an IV in your arm that breaks up blood clots. So once you've had a CT scan that shows no bleeding, but you're still having stroke symptoms, and the doctors believe that you're having a stroke, you may be offered a clot busting medication that goes in your IV and tries to break up the blood clot in the brain that's causing the stroke. And the second treatment that is available to some people who are having strokes is if the blood clot is particularly big and blocking off a larger blood vessel in the brain, then they can additionally may need to go for a procedure called an angiogram, which is where you have pictures of blood vessels taken while the patient is usually asleep under X-ray guidance. And if they can locate the clot in the brain, then it can be pulled out with a special stent-like device, or sort of sucked out with a sort of what's sort of like a mini vacuum device. And that process is called a thrombectomy. Many people may be more familiar with somebody who has a heart attack. They need to have a blockage in the heart that needs to be opened up. And in that case, they go for an angiogram of the heart. We do the same thing now for about almost the last 10 years to restore blood flow to the blood vessels of the brain. And I'll just pause here to thank Dr. Ana Aguirre for joining us. She's going to go see a patient now here at National Rehab Hospital. Yeah, just thank her for coming, and thank her for explaining to our Spanish-speaking audience about Rapido and the importance of recognizing signs and symptoms of stroke and sharing the Rapido acronym to friends and family in the Spanish-speaking communities.
Muchas gracias y bueno, fue un placer acompañarlos el día de hoy.
Bye. Thank you, Ana.
Hasta luego.
Thank you so much. I have some more questions for you from our audience, but before I do that, just want to remind our viewers that we are taking questions. Please ask them in the comments. We're here with Dr. Mary Carter Denny talking about different types of strokes, signs and symptoms. And we got a question from Gloria. She asked, are strokes considered to be hereditary?
That's a great question. Most strokes are not hereditary. The main risk factors for stroke, the things that put you at higher risk for having a stroke than other people, are things like high blood pressure. That's probably the number one thing that puts you at risk for stroke. Diabetes, particularly if it's uncontrolled, so very high blood sugar, high cholesterol, particularly also if the cholesterol is very high and you're not on cholesterol medications. So those are the three, I would say, main risk factors for stroke. The other one that affects some people is called atrial fibrillation, which is an irregular heartbeat that causes clots to form in the heart, and then the clot can go from the heart to the brain, and that can cause a stroke. So those three main risk factors, the high blood pressure, diabetes, and high cholesterol, plus this irregular heartbeat called atrial fibrillation that mostly affects older adults, typically people over the age of 60. Those things are the main causes of stroke. Most of those, some of those can run in families. So I guess if you've had a family history with lots of people who have very high blood pressure, in that sense, that you could be at higher risk for stroke. So in that way, I guess you could think about strokes as being hereditary. It's not the stroke itself. It's more like the things that put you at risk for stroke. Atrial fibrillation usually is not hereditary. It's just a condition, an irregular heartbeat that affects people as they age, as they grow older, and often in people who've had high blood pressure over time. So I would say there are some risk factors for stroke, particularly high blood pressure, that may run in families, and those could increase your risk of stroke. But it's not as if one person in your family has a stroke, then you necessarily going to have a stroke as well. In fact, 80% of strokes are preventable if we're able to do things like eat a healthy diet with lots of fruits and vegetables and lean proteins, exercise most days, try to get 30 minutes of whatever exercise that you like to do that you can keep doing about 5 days a week, and then keep control of your stroke risk factors being high blood pressure, diabetes, and high cholesterol. So doing those lifestyle things, diet and exercise, plus keeping an eye on control of your stroke risk factors really can reduce your risk of stroke a lot, even if high blood pressure runs in your family, or even if high cholesterol runs in your family. There's a lot that you can do to reduce your risk of stroke.
Thank you so much. Yeah, that was going to be another question of mine. How can you reduce or minimize your risk? Can strokes be prevented?
Yes, so that's what I was just speaking to, actually. It's a related question. So about 80% of strokes are preventable. So not every single stroke is preventable, but based on the studies that have been done previously, big studies with tons and tons of patients, about 80% of strokes are preventable if you are taking the right medications to prevent strokes based on your risk factors. So for if you have high blood pressure, making sure you're taking your blood pressure at home, checking your blood pressure maybe once a day, and then bringing those readings to your doctor when you go for your regular checkups. Diabetes, if you go for your general checkup, having your blood sugar checked maybe at least once a year, more frequently if you know that you have diabetes, and keeping control of your blood sugar. And then high cholesterol. If you know that high cholesterol runs in your family in particular, making sure that that is checked at your annual primary care visit. And if you have high cholesterol, making sure that you're doing the diet and exercise modifications and maybe taking medications to make sure that your cholesterol goes down to the normal range would be really important. For people who've had strokes, particularly ischemic strokes, often a blood thinner medication is recommended. For instance, aspirin, or another medication called clopidogrel, or another medication called apixaban. So there are several others that are related, but those are, I would say, the three most common medications. If you've had a stroke or a TIA, which is a transient ischemic attack, sometimes called a mini stroke, you may also be recommended to take a blood thinner medication for stroke prevention.
Thank you very much. That leads to another question from our audience related to stroke survivorship. And I don't know if any of the medications that you mentioned are considered a statin medication, but Gloria had a follow-up question. Should a stroke survivor be on a statin medication?
Yes. So the main cholesterol medication that we take, or that we recommend that people take for lowering cholesterol, is called a statin medication. The two main medications that are most often prescribed, in terms of statins for high cholesterol to reduce the risk of stroke, are called atorvastatin and rosuvastatin. And that's based on two big clinical trials that were done, one in the United States and one done in Europe, that show that using statin medications, particularly well-studied are atorvastatin and rosuvastatin, taking those medications and aiming for an LDL cholesterol goal less than 70. So LDL is the quote unquote bad cholesterol. If we aim for an LDL goal less than 70, we know that that can reduce the risk of stroke, a second stroke, in somebody that has already had one. So yes, most people who have had an ischemic stroke will be recommended to take a statin medication to help lower their cholesterol.
Okay, thank you so much. I heard you mention mini stroke. Can you explain what a mini stroke is?
Yeah, so the term mini stroke is often used in place of transient ischemic attack, or TIA. So the symptoms of a TIA, or transient ischemic attack, also called a mini stroke by some people, are the same as a stroke. So you could have, just as in our BFAST acronym, you could have sudden loss of balance for B, E, for I, sudden loss of vision or double vision. You could have sudden facial droop. You could have sudden A, arm weakness, or sudden S, speech difficulty. And in all those cases, it would still be time, to call 911 to get medical care. In a transient ischemic attack, the T stands for transient. So that means the symptoms go away, often within an hour, and always within 24 hours. And it's because the blood vessel that was blocking off blood flow to the part of the brain that was being affected in the stroke dissolves on its own. So the damage to the brain is not permanent. So when you have transient stroke symptoms, and then you have that go away typically within an hour, and hopefully by that time you're already at the hospital, and then you have an MRI scan that confirms that there was no stroke, no permanent injury to the brain. That is what is often referred to as a mini stroke, or TIA, transient ischemic attack, but the symptoms are the same as a stroke.
All right, thank you so much for explaining that. I have another question from our audience. This is from Derek. Can you regain full strength after suffering an ischemic stroke? I'm gonna keep saying that the wrong way.
It's okay.
How
Ischemic.
long,
That's okay.
ischemic, and how long could the process take? And also, will the numbness ever go away?
That is a great question. So, um, uh, some people regain full strength, and some people regain full sensation after a stroke. Not everybody does. And most of the recovery in terms of strength and sensation happens in the first year after a stroke. The recovery is the fastest in terms of your gains of strength and sensation back to your normal in the first 3 to 6 months. So, for instance, if somebody had a stroke in December, those first 3 months, so until March, and definitely up to 6 months until June, would be really crucial in terms of their physical therapy, speech therapy, occupational therapy, all of their therapies to regain their speech, their sensation, their strength. And even after that 3 to 6 month period, you can still make additional gains. And certainly even after a year, there are people who improve in terms of strength, sensation, and speech, but it's a slower process, and it's possible that the strength and the sensation may not go back to normal, maybe not ever go back to completely normal. But I always tell my patients that the window for recovery is actually longer than we initially thought. We thought it was only really in the first few weeks to months that people were getting stroke recovery, but now we understand that that process may be much longer, and may be enhanced by continuing to work on your physical therapy, continuing to do your home exercises, if you've been given those by your rehab therapist, and obviously also being on the correct medications to prevent strokes as well.
Okay, thank you so much. I want to talk a little bit more about treatment. When should patients start being monitored or seek treatment for a stroke?
So as soon as you have any stroke symptoms, then they should seek treatment. And that means calling 911 and getting to the nearest hospital that treats stroke patients immediately. That is any stroke symptoms, we really encourage people to come immediately to the emergency department, because all of the treatments that we have for stroke, I spoke earlier in the program about a clot busting medication called TPA or TNK, and also a procedure to pull out blood clots from the brain called thrombectomy. Those are very time sensitive. They only really work well in the first few hours. Sometimes that time window can be extended, but they really work the best the sooner somebody comes to the hospital. However, in terms of prevention of strokes, you can start that in childhood, in your making sure that your children get their well child checks, making sure that they're getting regular exercise, eating a healthy diet, and for us as adults, making sure that we stay true to doing all the things that we're telling our children to do, such as eating a healthy diet, lots of fruits, vegetables, lean proteins, trying to stay away from processed foods as much as we can, trying to stay away from red meat, and also like full fat dairy, like full fat cheeses, full fat milk, and staying active as much as we can, getting back away from behind our desks and getting out for a walk at lunchtime. Even a brisk walk of 20 to 30 minutes at lunchtime really does make a difference. In addition to following up with our own doctors, making sure that you're going to your regular checkup every year. If you have certain medical conditions that require additional treatment, making sure you make it to your follow-up appointments. If you have particular needs to follow up about your diabetes or high cholesterol or high blood pressure, which are all risk factors for stroke. And if they're well controlled, then you're lowering your risk of stroke. So stroke prevention starts in childhood, pretty much starts from day one, but acute treatment for stroke or possible stroke really needs to start as soon as you have any kind of sign or symptom of stroke. And I'll just review it one more time, bears repeating. If you want to pull up our Be Fast picture there. So Be Fast is for the signs and symptoms of stroke, and to emphasize the importance of people getting treatment quickly. So B is for balance, sudden loss of balance. E is for eyes, sudden loss of vision or double vision. F is for facial droop. A is for arms, the arm drifting down or becoming weak. S is for speech, sudden surge speech. And T is for time to call 911. The only stroke symptom that is sometimes accompanied by these that is not included here is sudden severe headache, especially if you're not a headache person. So sudden severe headache, like the worst headache of your life, and you are not a typical headache sufferer, could also accompany these symptoms, and should be also something that you seek medical care for. So hopefully that's helpful, and happy to take any other questions or yeah.
I have more questions for you.
Great.
So if a stroke does occur, so you recognize the symptoms,
Yep.
you call 911, can you or a loved one choose where you receive care?
That is a great question. So and the short answer is it depends a little bit on where you live. Most cities now have gone to a protocol where if somebody has having very obvious signs of a large stroke, particularly they have a facial droop, they cannot move their arm or their leg, often their eyes are turned to one side, then those patients who have what looks like a more severe stroke are triaged by our EMS services, emergency medical services, to bigger hospitals that can take care of more severe strokes, so a comprehensive stroke center. And for everybody else, they will go to the nearest hospital. That's the protocol for most places. In some jurisdictions, in some states and cities, they do allow people to give a preference of their treating hospital, as long as the distance isn't further. So if you live the same distance from two hospitals, but one is your preferred hospital, then you can often give that preference and they will honor it. But if your preferred hospital is twice as far away as the nearest hospital that can treat you, then that request will not be honored, because the time that it takes to get to your preferred hospital is so much longer that it could actually affect your stroke outcome. So since all of the stroke treatments are time sensitive, even an extra 20 minutes is a big deal if you had to go across town, because in every minute, about almost 2 million brain cells are at risk for dying because they're not getting enough blood flow and not enough oxygen and not enough blood sugar. So it is a very time-sensitive condition, acute stroke. So that's why in some cases you would be allowed to give a preference, but if your preferred hospital is much further away than the closest hospital that has stroke treatment, then that request is usually not honored based on EMS triage protocols. So I hope that makes sense.
Yeah, no, that makes sense. You mentioned the comprehensive stroke centers. I know MedStar Washington Hospital Center, MedStar Georgetown University Hospital, and MedStar Franklin Square Medical Center are all comprehensive stroke centers. What does that mean?
Yeah, so that's a great
complex patients.
Yes, that's a great question. So at comprehensive stroke centers, they are hospitals where we can take care of the sickest stroke patients, the people who are having larger strokes, the people who might need the thrombectomy procedure. They're having a larger blood clot in the brain that is blocking off blood flow, that might require that procedure called a cerebral angiogram and thrombectomy to pull out the blood clot. Those procedures generally are only done at comprehensive stroke centers. So smaller community hospitals just don't have the capability and the staff to perform those types of procedures. And that's why many places have moved to, many EMS, so emergency medical services, have moved to a protocol where they triage patients with the most severe strokes to go to those comprehensive centers. In Washington, D.C., 2 of the 3 comprehensive stroke centers are, as you mentioned, MedStar Washington Hospital Center and MedStar Georgetown. The third one is GW Hospital. But you know, we're very lucky to have great stroke care here in the District of Columbia. And that's great. And also in the Baltimore area, really grateful to have MedStar Franklin Square added as a comprehensive stroke center, because despite having 2 other institutions that also provides comprehensive stroke care, Baltimore was really underserved in terms of acute stroke care and ability to provide the highest level of comprehensive stroke care until MedStar Franklin Square worked really hard to build their team, and a really fantastic group there to provide very high level stroke care and stroke resources. In addition to thrombectomy procedures, comprehensive stroke centers have dedicated neurology nurses. I want to give a shout out to all of our neuro nurses. It's Neuro Nurses Week. And so recognizing how important our neurology trained nurses are in treating our patients who are admitted for stroke, and also following them up in our clinics too. So our neurology trained nurses are really specialized in understanding what stroke patients need in their evaluation for what caused their stroke, recognizing very subtle changes in how they're doing that might need urgent evaluation to see if they're having a new complication, or recognizing you know, how to work with an interdisciplinary group of people. So physical therapists, speech therapists, respiratory therapists, occupational therapists, doctors, case managers, social workers, neurosurgeons. So we have a really big group that takes care of stroke patients at our comprehensive centers. And our neurology nurses are really the core of that team at the bedside. So shout out again to our neuro nurses for Neuro Nurse Week here in the DC and Baltimore area.
Yes. Thank you for that. That is great to recognize. So it sounds like the teams are really working together. So and you talked a lot about for stroke patients, what about if someone goes to, say, a primary care physician's office and they are presented with stroke symptoms? What is that process like? We talked a lot about if you're a loved one, calling 911, but what if you're at another doctor's office? What is that process like? How do physicians, MedStar specifically, work together to make sure we're caring for that stroke patient?
Yeah, so if you, I think if you called your doctor's office and said, you know, like just 20 minutes ago, my arm went completely weak and I can't move it, they would tell you to call 911 and go to the closest emergency department. If you happen to develop stroke symptoms soon after you arrived at a doctor's appointment, or you had a doctor's appointment already that day and arrived to your doctor's appointment with stroke symptoms, I think that they would also, you know, ensure that you got as quickly as possible to the closest emergency department. So I do think that we work well together to try to streamline that process. A few years ago, we had a staff member at MedStar Georgetown University Hospital who had a stroke while at work, and got that patient quickly to the emergency department and got them treated for a pretty big stroke, and you know, thankfully made a great recovery and was able to go home just a few days later. So I do think that our primary care colleagues are really crucial in helping manage stroke risk factors, and also helping us you know, be sort of the front line if somebody's not sure if they're having a stroke and they call the doctor's office or show up to the doctor's office, to making sure that they get to the nearest stroke ready and stroke capable hospital.
Okay, thank you so much for that. I have some more questions from our audience that I'll ask you next. This one is from Michael. Is it best to try to control high triglycerides with statins alone or use statins in combination with fenofibrate?
Oh, wow. Very specific question.
Yes.
The latter. So often high triglycerides require not only statins, but another medication like fenofibrate. But that's a great question to ask at your annual primary care doctor's visit, or if you have a cardiologist, your annual cardiology visit. But often very high triglycerides, especially if they run in families, require a statin medication plus an additional medication like fenofibrate.
All right. Thank you so much. Question from Candace. She said, my aunt had a TIA. Is it likely that she could experience another stroke in the future?
Thank you, Candace, for that question. I'm sorry to hear about your aunt. I think of a TIA sometimes like a warning sign that a stroke could occur, and a stroke that sort of sticks where the symptoms don't go away. So there's a particular rating scale that we use for the percentage of likelihood that you could have a stroke after you've had a TIA. But I think the main point here is that your aunt may have the opportunity to see your primary care doctor, see a stroke neurologist like me or one of my colleagues, and ensure that she's on the right medications to prevent a full-blown stroke. So that's a really important part of what we do, is to in our stroke clinics is to see people who have had a TIA or a stroke, and making sure that they're on the right medications, they're doing the right things to prevent a second event or sometimes a first stroke if they've had a TIA. And part of that includes understanding why they had the first TIA in the first place. And so hopefully that's helpful.
Yes, thank you so much. And one more question from our audience. This is from Gloria. Gloria, thank you for all your great questions. She asked, what is the percentage and time factor of having future strokes? I understand that there are low risks in increments of time to years. Is this accurate?
I would say the highest risk time period seems to be in the first 3 months after a stroke. So somebody had a stroke, let's say in December, like the example I gave previously, the highest risk for another stroke is in the first 3 months. There is also a risk going forward, but the highest risk of recurrence seems to be in the first 3 months and often in the first 30 days. So that's an important sort of milestone, is the first 3 months after a stroke, because hopefully by that time, we've identified what caused the stroke, whether it was related to atrial fibrillation or very high blood pressure, or another cause that it might be more rare, and gotten on the right medications in addition to the correct healthy diet and exercise, gotten those things sort of in line. And then, making it to the 3-month mark is often felt to be very important, because that's the highest percentage risk of having a second stroke. But as you go on, as more time goes on from the initial stroke, your risk should decrease, although it doesn't ever go back to zero, or it never goes back to what it was, or never goes back to the same as somebody who hasn't had a stroke. Let's put it that way.
Okay, thank you so much. I have 2 more questions for you before we wrap up our broadcast. So we talked all about prevention, risk factors, if you have a stroke, what to do, or if you think someone that is in your family or close to you, you notice any of those signs and symptoms in our Rapido or BFAST acronyms. What happens to our patients after they have a stroke? What is that like? And if someone has a stroke, what would they expect in terms of recovery?
Yeah, so that's a great question. And that's one of my interests. I really am focused on ensuring that everybody, regardless of their age, race, ethnicity, gender, geography, has the best chance of making their fullest recovery from stroke. And so I think that process often involves physical therapy, speech therapy, occupational therapy. People who've had strokes are evaluated for their need for those therapies while they're in the hospital. And then they may need to go to a rehabilitation hospital like MedStar National Rehabilitation Hospital, or another type of rehab facility before they go home. And then when they go home, they might need to do those types of rehab therapies at their home, or at an outpatient physical therapy clinic or speech therapy clinic. So a lot of it in the beginning is about getting in touch with the right therapies, and working, with the therapist in the first several months to recover. On average, for all stroke survivors, in terms of, let's say, arm strength, the strength may recover about 70%, but that means some people have, sort of 0% recovery. It never recovers at all. And some people have 100% recovery in terms of arm strength. So I think that a lot of it involves following up with your primary care doctor as well, and hopefully with a stroke neurologist like myself or one of my colleagues, to understand what caused the stroke, get on the right medications, and be on the right, doing the right diet and exercise to prevent strokes, and then working with our rehabilitation colleagues to sort of get you back on your feet, and get people moving again and speaking again.
All right, thank you so much. Can you talk about your study called STRIVE, which focuses on health equity for our stroke patients?
Sure, I'd love to. So STRIVE stands for the Stroke Research Initiative to Advance Equity. And STRIVE is really focused on trying to understand the different factors that may affect stroke recovery. So we know that rehabilitation therapies are important. We know that medications are important, but there are other factors that may influence stroke recovery as well. So a broad umbrella is called the social determinants of health, also called social factors, which influence health outcomes. So for instance, one main social determinant of health is transportation. So if you have difficulty with accessing transportation because you live in a place that doesn't have metro access, or you don't have easy access to a car, then getting to your medical appointments for follow-up is really difficult. Or if you live in an area of town where it takes a long time for you to get to the nearest doctor's office, or even the nearest hospital, that can also lead to worse health outcomes and worse stroke outcomes. We also know that not everybody can feel welcome in the medical environment. Some people's concerns may have been dismissed by previous physicians. And so if people feel like they've been discriminated against in any way, or there's been bias in the way that they've accessed healthcare before, they are less likely to seek care and do their follow-up visits. So the STRIVE study is really about following stroke patients over the entire year after they've had a stroke, to see how they're recovering in terms of their strength, their speech, their ability to do things around the house, get back to work, and also trying to understand from their perspective, both the stroke survivors and also their caregivers, who are often family members, how these social determinants of health, like access to transportation, access to medical care, how those things may impact their stroke recovery, and how they feel that they're recovering from stroke, in addition to any biases that they might experience generally in their communities, but also in the medical field. So our goal in trying to understand from the patient and family perspective about their stroke recovery is so that we can develop interventions and do better. Even the most caring health system, which I think we are, can can even do better by, asking the patient and family perspective, understanding what barriers they face in their stroke recovery, so that we can do our best to work with them to think about ways and develop ways that everybody, regardless of their background, has excellent access to all of the therapies, all of the doctors, all of the medications, all of the support that they need to recover from stroke.
Thank you very much. That sounds like a great study. Well, that's all the questions I had for you today. Before we wrap up our broadcast, what is a key takeaway or one thing you want to make sure that people take away from the conversation we had today about stroke?
I think the key takeaway is that I really want everybody to know that if you see somebody that might be having symptoms of a stroke, which could be facial droop, arm weakness, speech difficulty, difficulty with your balance, or difficulty with your vision, or sudden severe headache, that they call 911. And I think that that's important for all people from all walks of life. And I'll add a second sort of key message, which is that we hope to work very hard to expand our education efforts to include more Spanish speakers with the Rapido acronym, which means Rapido means fast in Spanish, and helping them to also be able to recognize the signs and symptoms of stroke and the importance of calling 911 quickly. So it was great to be here today. Thank you for having me. And thank you so much for all of the great questions.
Yes, of course. And thank you for being here. We really appreciate the time. We know you're extremely busy, so we appreciate you taking the time to educate our patients with this wonderful information. Thank you to our viewers for joining us and asking your questions. If you would like more information or to schedule an appointment with a neurologist in the Washington, D.C. region, you can call 202-877-5026. That's it for our broadcast today. Thank you so much for joining. We really appreciate it.
Take care, everybody. Thank you.